Okay. Okay. Next. Okay. Good morning, everyone. Okay, this is Dr. Rashmi from OBG. Yeah, so we are going to deal with a very important topic, particularly with respect to treating all the diseases in your obstetrics, in gynecology. You need to have a very basic understanding of the hormones, which play a very important role in the life of a woman. Okay, so we need to understand how and where these hormones are produced. What are the end organs where these hormones are going to act? So why is it important that you need to have a very good understanding of the hormones? See, tomorrow when you become doctors and when people come to you, or young girls or a woman in her reproductive age group or a postmenopausal woman, they come and tell you some simple problems, like a very young girl may come with her mother telling that she has not yet attained menarche, or at the age of 10 only we are seeing some signs of puberty, or a girl can come and tell that she's having a lot of pimples on her face, or there's excessive and unwanted hair growth on her face or on her rest of the body. Or you say, there is a woman who comes and tells that her periods are irregular, or she doesn't, for 6 months, 7 months, she doesn't get her periods. Or some people, when they come and say that she's bleeding excessively, or she's bleeding very scantily, or sometimes we get these women who come and tell us that they're angry for no reasons, they are irritable. So, or sometimes we get this postmenopausal females who come and tell that they're having hot flushes in their body, and they are having vaginal dryness, and a lot of irritability, mood swings. So all this, to understand all these things and to treat them appropriately, you need to have a thorough understanding of hormones in gynecology. Okay, so this is the basic introduction which I wanted you people to understand as to why you need to have a thorough understanding of this topic, that is hormones in gynecology. Okay, so coming to the introduction, the neuroendocrine system forms the basis of menstrual and reproductive cycles. So what are the important organs, particularly in a female and with respect to her reproductive system? What are the organ system involved? So HPO axis, you have heard about it, right? So it is the hypothalamus, the pituitary, and the ovaries. Apart from this, we have two more additional organs. One is the adrenal gland, and second is the thyroid gland, which play a very important role in the woman's menstrual and reproductive cycles. Okay, so coming to the hypothalamo-pituitary-ovarian axis. So this is it. There's a hypothalamo-pituitary-ovarian axis. You can see in the picture on the right hand side. So the most important is we have the hypothalamus. So this hypothalamus produces a very important hormone, that is the gonadotropin releasing hormone, which acts on the pituitary. Okay, the pituitary produces, I'm going to talk about it in detail, but in general I'm going to talk that hypothalamus acts on the pituitary acts on the end organ, that is the ovaries. Okay, and that ovary produces certain hormones. So hormones from the hypothalamus, pituitary, and ovaries, they are all interdependent, and they form a well-coordinated axis called as the HPO axis. So these secretion of these hormones by the hypothalamus, the pituitary, and the ovaries, they are all regulated by a feedback mechanisms, and also they are also affected by other organs or other glands like the thyroid and the adrenals. So when does this HPO axis start becoming functional? So it starts becoming functional as early as the fetus is in the womb of its mother, or the girl child or the girl fetus is inside the womb of the mother. So the HPO axis is active and functional from around 20 weeks of fetal life. So this is how the fetal ovaries are present inside the girl fetus. Then the next activation, it remains dormant for the first 10, 11, 12 years till she attains puberty, So all that time it remains dormant. So around the time of pre-puberty and puberty, so what happens is the feedback mechanisms becomes all of a sudden extremely sensitive. The receptors become sensitive. So the HPO axis is responsible for, so note the word here, the pulsatile release of GnRH. How this GnRH is released, whether it is released in a continuous fashion or whether it is released in a pulsatile fashion, is very, very important in order to treat so many disorders in a female. Okay, so what happens around puberty is there is the pulsatile release of gonadotropin releasing hormone, and this causes the release of gonadotropins. And from where are these gonadotropins released? They are released from the pituitary, right? So because based on this, the LH and FSH, then what happens is that brings about the onset of puberty. So what exactly happens in puberty? Suddenly a small girl starts noticing the changes in her secondary sexual characters, and there is a pattern of how these changes occur in a woman, in a small girl. Okay, so the first thing which we notice in a very young girl, okay, say around 10, 11 years, 12 years, the first thing which a girl notices is she starts seeing development of hair on two particular areas of her body. One is on the mons pubis, okay, that's called as the pubic, and on the development of the axillary hair. So these two together we call it as adrenarche. Okay, so the development of thick coarse hair on her mons pubis and the axillary region. That's the first thing or the first sign of puberty. Next comes the thalarche, wherein you start noticing, she starts noticing the development of the breast. Okay, so what is the pattern? See, this is an entrance question for all of you. So what is the sequence of events in puberty? So first is the adrenarche, second is the thalarche, and third is the growth spurt. Suddenly the girls become tall, suddenly there is a increase in the height of the girls, and final and the most important and the culmination of puberty, and she becomes and she transforms from a girl to a adult or whatever. We can't say adult, but she has attained puberty, or the final event is menarche, wherein she starts seeing or the periods start and she starts menstruating or she starts bleeding. So what is the sequence of event? It is adrenarche, thalarche, growth spurt, and menarche, and all this is happening over a period of 1.5 to 2 years. Okay, so this is a slide which which reinforces what I have taught to you in the previous slide. So it is basically the hypothalamus which releases the gonadotropin releasing hormone, and this acts on the anterior pituitary. So the anterior pituitary produces two important hormones. One is the FSH, which causes the follicular development and in the ovaries, and it is responsible for the ovarian function. And then there is the release of luteinizing hormone, or the LH, which stimulates the ovulation. The sudden surge of LH brings about ovulation, and once ovulation occurs, the follicle from which the egg has been released, that becomes the corpus luteum, and which is the most important source of another hormone called as progesterone. So under the influence of FSH, the ovaries produces follicles. These follicles produce estrogen. Under the influence of LH, the follicle which has ovulated becomes the corpus luteum, and all other follicles disintegrate, and this corpus luteum produces another important hormone called progesterone. So you should have a very thorough understanding of how the feedback mechanism acts, so that you can use this knowledge in order to treat the woman later on, at any stage of her life when she comes with problems. If you understand how this feedback mechanism acts, you can use the appropriate drugs in order to suppress or enhance these feedback mechanisms, and resulting in getting the desired result. Okay, so basically we have three types of feedback systems: the ultra short loop, and the long loop. So I'm just going to give you a brief idea as to how in a menstrual cycle we have the follicular phase, we have the mid cycle, and the luteal phase, and how the feedback mechanism acts in bringing about the release of certain hormones. Okay, so always once the girl or a woman menstruates, the first 14 days, if suppose she is having a 28-day cycle, the first 14 days is called as the follicular phase. Around the 13th to 14th day, she ovulates, right? So first let us deal with the follicular phase. So what happens in the follicular phase? So first and foremost is the GnRH. Okay, so the LH-FSH levels are at its lowest. So the hypothalamus produces the hormone called as the GnRH. Okay, so this is a gonadotropin releasing hormone. So the gonadotropin acts positively on the anterior pituitary, releasing the hormones FSH and LH. So initially in the first half of the cycle, the FSH levels are high compared to LH. So what happens? The FSH is a follicular stimulating hormone. The name itself tells it's going to act on the ovary and stimulate the follicles. So there are so many follicles in the girl. So a number of follicles, say around 7 to 8 follicles, get recruited in that cycle and they start growing. Okay, they start growing and one of them becomes the dominant follicle, and under the influence of FSH, these follicles, the dominant follicles, becomes the Graafian follicle. So it is this Graafian follicle which produces a very important hormone called as the estrogen or the estradiol. Now, so under the influence of FSH, when the ovary starts producing estradiol, the levels of estradiol starts increasing in her body. Okay, so this estradiol, as the levels increase, it has a negative feedback on the anterior pituitary. So what happens? The FSH decreases. So particularly around 9th, 10th, 11th day, the FSH level starts coming down. Okay, so and there is the follicles are also less recruited and the estradiol hormone goes on increasing. There's negative feedback mechanism, the levels of FSH decrease. So meanwhile, this estradiol also acts on the endometrium of the uterus, and what happens is the proliferation of the endometrium. So I hope all of you have understood what exactly happens in the follicular phase. Now, particularly around mid-cycle, something else is happening. Okay, so again, under the influence of hypothalamus, the gonadotropin releasing hormone is produced in a pulsatile manner, which acts on the pituitary. Okay, but here what happens is around this time there is the sudden surge of LH. Okay, that is called as the pre-ovulatory LH surge. This pre-ovulatory LH surge will cause sudden increase in the estradiol, and what will happen? It causes a positive feedback mechanisms, and again there is an increase in LH surge in the next half of the cycle. So this pre-ovulatory LH surge is responsible for the ovulation to occur. So next comes the luteal phase. So in the luteal phase, what exactly happens is the gonadotropin releasing hormone again causes, so now what has happened already? The estradiol from the negative feedback mechanism, it has shifted to the positive feedback mechanism. So what is happening? There's increase in level of LH. So under the increased level of LH, the ovulation takes place, and whatever the Graafian follicle is there, it has ruptured to form the corpus luteum, right? So that corpus luteum starts producing progesterone, and this progesterone again, as the levels of progesterone goes on increasing, say around 24th, 25th day, the negative feedback mechanisms ensues on the anterior pituitary, resulting in decreased level of LH and FSH, and suddenly there is withdrawal of estrogen and progesterone in her body, and she starts menstruating. Okay. It's basically, what I have been trying to explain. Okay. So let us have a little bit understanding of what exactly, see the importance of this, understanding the hypothalamus in much more detail is it's going to help you a lot when you are going to deal with your the entrance questions. Okay, so basically you need to understand and memorize all these details so that you can tackle your entrance questions. Okay, so coming to the hypothalamus has 3 well-defined areas for hormone regulations. This can be asked as so one of this is not a a center for hormone regulation in hypothalamus, and they may give this 3 area and they may give one more area, right? So you need to remember these areas. Okay, so what are these 3 areas which are for hormone regulation? One is the supraoptic area, the tuberal region, and the mammillary region. And each of these regions is further divided into areas or nuclei. Both the tonic and cyclical centers are present, resulting in changes in GnRH production. Okay, so what are the connections here? Okay, so basically the connections are cortical connections to the pituitary. So cortical, what do you understand by cortical connection? They are nothing but the neural connections between the higher cortical centers like amygdala, hippocampus, thalamus, pons to the thalamus, hypothalamus. Okay. So coming to the pituitary, you know, there are two lobes of pituitary, the anterior and the posterior lobe. Okay, the anterior lobe is also called as the adenohypophysis, which is connected to the hypothalamus via a special portal system of vessels, whereas the posterior lobe, that's called as the neurohypophysis, from where the oxytocin is produced. Okay, so it is connected directly to the hypothalamus through the supraoptic and the paraventricular nuclei. Okay. So what are the other factors which you need to know here is there are some hormones which have an inhibitory effect and some hormones which have a stimulatory effect. So it is the epinephrine and the estrogen, they stimulate. Okay, epinephrine and the estrogen stimulate, whereas dopamine, serotonin, opioids inhibit the release of GnRH by the hypothalamus. Gonadotropin also inhibit the GnRH secretion. So gonadotropin releasing hormone, what exactly it is? It's a decapeptide. So the gonadotropin releasing hormone from the hypothalamus, that is the arcuate nucleus, acts on the anterior pituitary, that is resulting in the production of 2 important hormones, the luteinizing hormone, stimulating hormone. Okay, so the 2 things, you know, I want you to stress or to understand the fact that there are 2 things which are happening. One is the down regulation and second is the up regulation. If you understand the concept of down regulation, Vignesh, your network is causing poor call quality anteno barta idella. Network is causing poor call quality anta barta ide. You know, most of the diseases, most of the problems which a girl or a woman comes to you. Okay, so what is this down regulation? When the anterior pituitary is exposed to GnRH continuously, there is a decrease in receptor sensitivity and resulting in down regulation. That means if you give GnRH continuously, the receptors are going to become less sensitive. So suddenly the LA and FSH level. Okay, this is what we want sometimes. You know, we are going to use this knowledge to them. Second is the upregulation. So I told you upregulation. What is this upregulation? I told you that the GnRH has to be released in a pulsatile manner. This is very important. So when you expose the intermittently, or when there's intermittent of the anterior pituitary to the gonadotropin releasing hormone in a pulsatile manner. So what happens is the receptor sensitivity is increased, resulting in upregulation and resulting in production of the hormones LH and FSH. So what are the applied aspects? Yes. So down regulation is when you continuously give a woman, so we can produce GnRH hormones synthetically, right? So and when you continuously give a woman this GnRH, so what happens is down regulation. So how are we going to use it? So say, you know, the woman is having PCOD and her LH FSH levels are very high, particularly the LH levels are very high. So she's not ovulating. So initially, before you start her on an IVF cycle, what do we want? We want her LH FSH level to come back to that baseline level. So how do you get these hormones to a baseline? Give her continuous GnRH analogs. Okay, so that is called as regulating ovulation in a in vitro fertilization. Okay, And particularly the next applied aspect wherein you can continuously give her GnRH is in precocious puberty. You know that, a woman or, the mother gets her child and she says she's hardly 8 years or 9 years, and already I'm seeing that she's having the signs of puberty. What happens if she attains puberty? Her height becomes stunted, right? Her the fusion of the epiphysis takes place at a very young age. So what we get is a very small stunted growth with all signs of puberty. So we want to delay the puberty. So what do? You have to reduce the LH and FSH. What can you do? You can give her a continuous supply of gonadotropin releasing hormones so that you can suppress the menstruation in precocious puberty, so that you can bring about an increase in the height of such girls. Okay, and also this continuous exposure to GnRH can also be used in reducing the size of uterine fibroids. Now coming to the upregulation is by pulsatile release. You give cyclical release. Cyclically you expose a woman to GnRH. Okay, so what happens is it causes a cyclical release of gonadotropins and of FSH and LH later, and this induces the ovulation and helps in conception. Again, the knowledge of this we are going to use in your infertility, treating an infertile woman. Okay, so the same thing what I'm telling is synthetic analogs of gonadotropin releasing hormone are available in the market now. So what are their applied aspects? This is what you people should remember and should memorize is they need what are the applied aspects? Where do we use GnRH analogs is in order to shrink the size of uterine fibroids, shrink endometriosis, shrinkage of endometrium prior to endometrial ablation, hirsutism, precocious puberty, in vitro fertilization, and also in prostatic cancer. So what are the synthetic analogs which are available are the nafralin, that is 200 micrograms intranasally daily for 6 months. That's how the dosage is used. You need, it's good if you remember from the entrance point of view, yes, it may be useful to you. Okay, but as undergraduates, if you remember the name also, we are very happy. Okay, so what are the drugs you need to know? The nafralin, buserelin, depot injection of goserelin, okay, leupride, which is the most common the preparation we use even in our hospital is the leupride, which is nothing but 0.75 milligrams. It's given intramuscularly once in 21 days. Then other analogs are the triptorelin. Okay? And then we have also GnRH antagonist, which can be used in IVF cycles. Apart from this, you need to understand certain other hormones, certain other inhibitory factors. Then we have the prolactin inhibitory factors. The prolactin secretion from the anterior pituitary seems to be under the chronic inhibition of prolactin inhibitory factors. Dopamine is another very important physiological inhibitor. Okay, so then you should know thyrotropin releasing hormone. It's a tripeptide. It stimulates the release of not only thyrotropin, but also the prolactin from the pituitary. So other hormones which play an important role are the corticotrophin releasing hormone, GHRH, that's the growth hormone releasing hormone, and the melanocyte releasing factor. So we understood the hypothalamus. Now let's have a brief understanding of the pituitary gland. The pituitary gland, where does it lie? It lies in the sella turcica. Its size being 1.2 into 1 centimeters, and it weighs around 500 to 900 milligrams. Okay? It comprises of an anterior pituitary gland called as the adenohypophysis and the posterior pituitary gland called as the neurohypophysis. It consists of 3 histologically distinguishable cells. Okay? One is the chromophobes or the parent cells, the chromophil cells described as the eosinophil or the alpha cells, and the basophils or the beta cells. So the beta cells are very important here, So the beta cells secrete the gonadotrophins that control the ovarian function and the menstrual cycles. So these gonadotrophins are FSH, LH, TSH, and the corticosteroid hormone. Each of these hormones has an A, alpha, and the beta fractions. When alpha fraction is identified by, it contains, 92 amino acid, the beta fraction, it's non-specific, whereas beta fraction is specific in its action. Okay, it's again basically the same thing. Okay. So again, basically, whatever I have explained is, it's a this slide will tell you, how the interplay of LH, FSH, GnRH, estrogen, and progesterone. Okay, it's just the repetition of what I have explained to you. I'm not going to go into the details of these hormones. Okay, if you want, I can upload the slide and you can understand how FSH, and LH acts and what is their half-life. Okay, and what is their functions and what are their clinical implications. Okay. So these are the slides here. Okay. Coming to the adrenal glands. So in the adrenals, we have the zona glomerulosa, that is aldosterone is secreted from this zone. Then we have the zona reticularis and the fasciculata. They both act as a single unit. And the principal hormone which are produced from here are the cortisol, the corticosterone, that is the glucocorticoids, and the androstenedione, and androsterone, and DHEA, that is dehydroepiandrosterone. They are all collectively called as the androgens. And to some extent, some amount of estrogen and progesterones are produced by these adrenal. So this explains the presence of estrogen in a postmenopausal woman when the woman's ovaries are totally not functional. So whatever the amount of estrogen, progesterones, and androgens are there in her body is from the adrenal gland. So this constitute the extra ovarian sources of steroids. Adrenal hormones are important to healthy menstruation and stress. And the adrenal glands are the only source of testosterone in women, and after menopause, they are the only source of female hormones, that is the estrogen and progesterone. Coming to the thyroid gland, the thyroid follicular cells synthesize iodine containing T4 and T3 under the influence of TSH of the anterior pituitary. These hormones are related to body growth and metabolic needs. Ovarian function is markedly related to thyroid activity. Normal enlargement of the gland occurs during puberty, pregnancy, and menopause. Menstrual function may be significantly disturbed whenever the thyroid functions are disturbed. Okay. So how does thyroid affect your cycle? So you need to understand two things here. One is the hypothyroidism and hyperthyroidism. So basically what happens in hypothyroidism is the periods are farther apart. The woman has menses once in 2 months, 3 months, 4 months. So they're further apart, where what happens in hypothyroidism is the polymenorrhea. Okay. And then hypothyroidism can also be co-associated with polycystic ovarian syndrome. So there is an imbalance of estrogen and progesterone, okay, resulting in anovulator cycles. And most of the women with thyroid abnormalities comes to us presenting with infertility, okay, because basically the cycles are anovulatory, okay. So this completes hormones in gynecology part 1. And that brings us to the end of this class. Okay, thank you. Vignesh, mugito class attendance. Vignesh, attendance. Question ಬಂದಿದ್ದಾರೆ ಈಗ. ಏನ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ? ಸುನಿಲ್ ಈ ಚಾಟ್ ಹಾಕಿ ಏನು ಮಾಡಿ ಡೌನ್ಲೋಡ್ ಆಪ್ಷನ್ ಮಾಡಿ. ಇದೇ ನಿನ್ ಕೈ ಎತ್ತಿದಾರೆ ಅಂದ್ರೆ ಏನ್ ಡೌಟಾ? Raise your hand, ಏನೋ ಡೌಟ್ಸ್ ಇದೆ ಅನ್ಸುತ್ತೆ ಅಲ್ವಾ?
ಒಂದು ನಿಮಿಷ ಬಾಯಲ್ಲಿ ಡೌನ್ಲೋಡ್ ಆಪ್ಷನ್. ಹಾ
ಅಲ್ಲೇನೋ ಇತ್ತಲ್ಲ ಅಟೆಂಡೆನ್ಸ್ ತಗೋಬೇಕಂತ ಡೌನ್ಲೋಡ್ ಇತ್ತಲ್ಲ, ಅವ್ರಿಗೆ ಬರ್ತಾ ಇಲ್ಲ. ಕ್ಲಾಸ್ ಮುಗೀತು,
ಎಂಡ್ ಮೀಟಿಂಗ್ ಇದೆ ಬಟ್ ಅದು ಫಸ್ಟ್ ಅಟೆಂಡೆನ್ಸ್ ತಗೊಳ್ಳೋಣ ಫಸ್ಟ್. ತೋರಿಸ್ತಾರೆ
ಕರೀರಿ ಅವರಿಗೆ, ಲೇಟ್ ಮಾಡ್ತಾರೆ.
ಸುನೀಲ್ ಒಂದು ನಿಮಿಷ ಬಾಯ್. ಸುನೀಲ್ ಒಂದು ನಿಮಿಷ ಬಾಯ್. ಅಟೆಂಡೆನ್ಸ್ ಅಂತ ತಗೊಂಬಿಡ ಬಾಯ್.
ಮುಗೀತು ಕ್ಲಾಸ್, ಒಂದು ಅಟೆಂಡೆನ್ಸ್ ಮುಗಿಸ್ಬಿಡಿ. ಓಕೆ, ಎಷ್ಟು ಜನ ಇದಾರೆ ಹುಡುಗರು? 152. ಓಕೆ, ಇಲ್ಲಿ ಏನೋ ಚಾಟ್ಸ್ ಇದೆ ನೋಡ್ಬೇಕು, ಅವ್ರದ್ದು ಏನೋ ಡೌಟ್ಸ್ ಇರ್ಬೇಕು.